Hello everyone, welcome to this online course on ophthalmology. I am Dr. Huang from the Joint Santo International Eye Center, the JSIEC. Our topic today is viral keratitis. Our learning goals are to master the pathogenesis, clinical features, diagnosis, and management of viral keratitis. And before class, I would like to share you a case. A young lady was referred to an ophthalmic center presenting with painless blurred vision in her right eye for 2 days. She has a remarkable history but got a fever 1 week ago. You can see the pictures in her right eye stained with sodium fluorescein. So what has happened to her eye and how to manage it? I hope that after this course, you can perfectly answer these questions. Now let's begin our class. The herpes simplex virus, the HSV type 1, is the most common virus associated with keratitis, and is also the leading cause of corneal blindness around the world. Like bacterial and fungal keratitis, the herpes simplex keratitis is often induced by a fever, trauma, psychological stress, menstruation, and compromised immune status. The virus resides in the trigeminal ganglions and cause epithelial, interstitial, endothelial, and neurotrophic damage to the cornea. The underlying pathogenesis of HSV keratitis include a direct invasion by the cell-mediated immune reaction to the virus. Direct viral invasion mainly affects the corneal epithelium. Replications of virus induce a typical branching and linear pattern with terminal bulbs that is called a dendritic keratitis. The dendritic lesions can further expand or fuse together to form a geographic pattern which we call a geographic keratitis. On the other hand, indirect damage from HSV through cell-mediated immune response mainly affects the interstitial and endothelial layers. Typical changes include a central disc-shaped edema in the stromal layers causing disciform keratitis, while involvement of endothelial layers result in anterior uveitis and increased IOP, which we call endothelial keratitis. Herpes simplex keratitis is prone to relapse, especially when compromised immune status is present. In addition, it is characterized by a little eye irritation since the corneal sensory nerves are affected, thus reducing corneal sensation. The lesion is often gray and clean, and hypopyon is rarely seen, which is different from a bacterial and fungal keratitis. The definitive diagnosis depends on immunohistochemistry or PCR to identify the herpes virus. A typical dendritic or geographic ulcer with decreased corneal sensation is a valuable clinical clue. Other information include a recurrent history and the presence of triggering factors may also be helpful in the diagnosis of HSV keratitis. Administrations of antiviral drugs topically and systemically is important. Interferon alpha may be helpful to suppress immune response. Corticosteroids should be used only and with caution in disciform and endothelial keratitis. We need to monitor closely when using corticosteroids. And keratoplasty is considered in case of perforation or severe opacification of the cornea. Let's have a basic understanding of another viral keratitis caused by the varicella zoster virus. the varicella zoster virus, called VZV, causes both varicella and herpes zoster. VZV belongs to the family of herpes viruses. This virus can cause scleritis, keratitis, uveitis, optic neuritis, and cranial nerve palsies. It affects the skin innervated by the ophthalmic division of the trigeminal nerve. Sometimes we can find a pseudodendrite keratitis as well as stromal necrosis and vascularization. Hutchinson sign describes the involvement of the skin supplied by the external neural nerve, a branch of the nasociliary nerve supplying the tip, site, and root of the nose. The dermatitis also affects the immunosuppressed AIDS patients, and shingles can be an early manifestation of HIV infection. Let's make a summary. Viral keratitis, here we refer to the herpes simplex keratitis, is often associated with a history of fever, trauma, menstruation, immunosuppression. Dendritic or geographic ulcer and disciform stromal lesion are the findings on ocular examination. Immunohistochemistry and PCR are variable for identification of the specific virus. Antiviral treatment is needed, and corticosteroids can be used with caution in the disciform and endothelial form. Here is a summary of the various types of infectious keratitis. You should keep in mind the differences between bacterial, fungal, and viral keratitis. This will come in handy in your clinical practice. I want to express my gratitude to Professor Fieda Law from the Medical College of Shantou University and Professor Lin Yi Liang from Zhongshan Ophthalmic Center for their advice on this work. Thank you very much for joining, and welcome to our new Joint Shantou International Eye Center in the future.